So full disclosure here, right? This first lecture when we talk about concussion is it's a little complicated, right? So we may need to review this a little bit on Friday, right? We may need to review this a little bit on Friday. Um, but it's super important so that you guys have a well-rounded knowledge of concussion to go into this level of detail, right? A lot of times we tend to focus on symptoms and we tend to focus on the exam, which we should, right? But it also behooves us. Uh, it behooves us to have an understanding of what's going on metabolically in the brain as well. Okay. All right. All right. Here we go, guys. So when we talk about concussion, right? Um, Concussion can happen after any blow to the head, any impact to the head, face or body, right? So after that initial impact, whether it's to the head, whether it's to the chest, body, whatever it is, right? If we see, kind of, someone's head kind of whip back and forth like this, right? The brain essentially strikes the inner wall of the skull. So we can see in this picture here on the right, okay, that with concussion, the brain strikes the inner wall of the skull, and that is essentially the classic mechanism that we've understood that results in concussion. Okay, so when we talk about the type of mechanics that happen with concussion, there are two specific mechanisms that we need to be aware of, right? There's coup, all right, coup and contra coup. Um, coup, okay, that refers to that initial impact when the brain strikes the wall of the skull. So when someone maybe that their head, kind of, the head breaks down that C-spine or hit the ground. That's the first impact of the brain against the wall of the skull. But remember, the skull is a closed space, like we've learned. So, right, the brain has nowhere to go but the opposite direction once it hits the ground, right? And so once the brain essentially hits the back wall of the skull, it then travels forward and strikes the opposite wall of the skull, right? And that is a contra coup. Okay, that's contra coup. So coup, first blow when the head hits the ground. Contra coup, the brain essentially decelerates and strikes the opposite wall of the skull. So the front. So in this case, the front wall of the skull. Okay. So ultimately, right, that describes the impact. And you guys, please stop me if you have questions. Okay, that describes the impact. But right, okay, that's great. We know what happens, from an impact perspective. Coup contra coup. But what about the brain tissue? Okay, what about the brain tissue? So when someone takes a blow to the head, the body, the face, right, and sustains a concussion, right, there are essentially linear, so anterior, posterior, right, and rotational forces that actually happen, right, on the neuron, okay, in the brain on the neuron, right, and there actually can be essentially stretching and or potential tearing of those neurons, right? So who remembers, guys, and this is a question for you, who remembers when you guys took modalities? Who remembers what the difference is between primary and secondary injury? Who remembers what that is? Anybody remember?
Do you mean like the initial injury and then re-injuring it X amount of days, weeks, months later?
Okay, so do you guys remember? Um, I'm assuming that you went over this in modalities. Do you guys remember, like, so you talked about, for example, when someone like sprains an ankle, right? That's the primary injury. That's the tissue destruction from, the mechanism of injury. And then after that, we have those macrophages, those white blood cells that come in and start essentially, debriding the injured tissue, right? And we have those vascular changes to the injured area. But sometimes those vascular changes kind of they kind of get carried away, right? And we have essentially hypoxic changes and death of normal tissue after an injury as well. And that's why we use ice, right, to essentially slow down the inflammatory process and essentially preserve healthy tissue. Do you guys remember that, or am I
I think we
okay?
called
All
it
right.
secondary cell death. something like that.
Yeah, pretty much. Yeah.
Yeah.
Secondary injury, secondary cell death. Absolutely, yes. Okay. Now, the same concept applies here. Okay. The same concept applies here. So when we have that that initial shearing, okay, or rotation of the neuron, right? Um, that essentially results in an inflammatory cascade, right? And we have these chemical mediators that essentially start flooding the neuron. All right. So this metabolic flood, okay, so to speak, is often referred to as the neurometabolic cascade, okay, of concussion. And this is actually the component of concussion that we understand the least. Okay. And so we've made a lot of advances. And as you guys are going to see as we work through concussion, really honestly over the next, I would say over the next 3.5 weeks to a month, we're going to spend some time here, right? That we've made a lot of advances in regards to rehabilitation, in regards to all these types of things, and so there's a lot more that we know that we can do, right, as opposed to just telling someone to rest until they feel better, right? But this neurometabolic cascade and the the neurochemical and the microscopic changes that happen, right, this is the thing that we still know the least about, right? We've had some updates here, but this is the biggest piece of the puzzle that we don't know how to solve. Okay, when it comes to concussion, we know that this happens, but we don't necessarily understand what to do about it. And this could still be a significant reason why some people, okay, still have suboptimal outcomes, even with the best concussion management, right? Okay, so aside from that neurometabolic cascade, right, and we'll talk more about that in a second. But there are also, and as you guys can see here, there are actually vascular changes as well, right? And also neurological changes, right, in the brain post concussion. So if you take a look, okay, so this is a picture. You guys remember how we said that in our spinothalamic tract and our dorsal medial lemniscal tract, or our medial lemniscal tract in the brain, it essentially terminates at the thalamus and then sends the messages from the thalamus, right, to the premotor, or I'm sorry, to the precentral and postcentral gyrus, right? So this guy's is actually the thalamus here. And if we look on the left side, right, it almost kind of looks like a giant eyelash. Okay, kind of a goofy way to maybe think about that or explain it. But um, what do you notice? What do you notice? Let's look at the picture on the left first. What do you notice about this, about the thalamus here, and the projections going out to the gyri? Okay, as opposed to this one after head trauma. What looks different about these two pictures?
It looks like the one on the right just got snipped at the base.
Okay, so definite, changes. Uh, and this is a study called this is actually diffuse tensor imaging, or DTI. This is not uh, this is not something that's actually readily available. Um, you know, in your standard hospital or medical center. This is really only in research centers and/or in academic medical centers where this is actually available. But yes, Drew, you can see by taking a look, um, at the pictures here, that it looks like a few of those fibers have actually been, maybe damaged, or that there's almost even fewer of them. So there's definitely potentially um, some damage to these fibers, these projections from the thalamus, right? Okay, and so ultimately too, okay, if we take a look, right, and then this is so Christopher Giza, right? Christopher Giza was basically the pioneer. He's a physician, but he was essentially the pioneer of this neurometabolic cascade, right? And ultimately what we see here, right, with concussion is this giant influx of calcium and this giant outflow of potassium, okay, from the neuron itself, right? And ultimately, okay, what this results in is essentially a cytotoxic environment inside of the cell. Okay, now, um, you'll see, right, we have that essentially we have this neurometabolic pump, okay, that not that controls essentially sodium and potassium, but that the influx of calcium disrupts that neurometabolic pump, right? And the first thing that you see is that we don't have the ability anymore to essentially make ATP, right? And break down ADP or break down ATP into ADP, right? And so ultimately what that means is that this nerve cell can, or this cell can no longer utilize glucose the way that it needs to. Okay. And so there's altered neurotransmission, and we have the influx of this chemical known as glutamate. Okay. Glutamate is essentially a neurochemical that actually regulates inflammatory response. And in this case, has also been thought to actually kind of facilitate, right, hyperactivity of the sodium potassium pump at the nerve cell, right, and potentially exacerbate metabolic dysfunction. Okay, so a little bit more of a kind of a dive into this. Okay, we can see that with this neurometabolic cascade, right? Ultimately, what happens is look at first and foremost, right, the right after the injury, the influx of not only glutamate but potassium into the cell, right? Potassium essentially spikes, right, uh, to 400% of normal, right, and then our glutamate actually spikes to about 150% of normal as well. But the big takeaway here, guys, take a look at what happens to, okay, and then you can see this dotted line down here and this solid line down here. Take a look at what happens to glucose in the brain, right, and blood flow in the brain within the first week following injury, right? Take a look at this. So we can actually see that glucose actually falls to essentially half of the normal level or half of the baseline, okay, within the first week following a concussive injury. And that we have essentially changes in hemodynamics. So blood flow is also decreased, right, within the first week of injury. So, like we talked about, right, we have that acute neuronal injury, right, that stretching and torsion of the neuron, right, that damages the axon. Okay. Glutamate comes in, right, and facilitates this hyperactivity of the sodium potassium pump, right? And we have this large outflow of potassium and this large inflow of calcium, okay, into the brain. Um, excuse me, that facilitates essentially uh, the lack of glucose, right, and the lack of breakdown of ATP, right, and then ultimately that can lead to essentially cell death. So if you remember kind of what we talked about, um, kind of uh, kind of that increased kind of pressure on the neuron and that fluid, sometimes that can actually lead to not only metabolic breakdown of the cell, but actually also obviously complete and total death of the axon. Um, okay, so here's the deal, guys. Right? It's nice to learn about all these details when it comes to concussion, right? But we've actually been able to, over the course of years, kind of link part of this process to symptoms. Okay, so for example, okay, so that initial ionic flux, right, of glutamate, potassium, calcium. Okay, we've essentially correlated that to symptoms like migraine headache, light sensitivity, right, and phonophobia. Phonophobia essentially means noise sensitivity as well. Okay, we know photophobia means light sensitivity. Okay. Um, so obviously, due to our changes in ATP and our energy crisis, okay, low levels of glucose and blood flow, that makes us vulnerable to a second injury. So the bottom line, right, and as we'll talk about later, this is why reporting of concussions is so important. Because if someone sustains a second blow to the head or a second concussive impact while still recovering from a concussion, right? This can actually have uh, pretty serious consequences in some cases, right? Um, Protracted symptoms and even um, it, it can affect the ability of the patient to recover to the extent that they either don't recover at all, or even there are situations where this can be fatal, and we can essentially be dealing with something like second impact syndrome, right? Which we'll talk about. Excuse me. So obviously, guys, as we've talked about, okay, prolonged and chronic flux of ions into the nerve, into the neuron rather, is going to create a state of toxicity, right? And that's going to lead to breakdown of nerve fibers and axons, right? So if we remember that from last week, Wallerian degeneration, right? It's a very similar concept, right, in the brain as well, right? And so obviously, we think that that continued toxicity leads to symptoms like migraine and light sensitivity, right? Um, and that ultimately the disrupted synapse, right? So if I've got two neurons here, right, the connection between the two is a synapse, okay? But if I have one neuron that's injured, okay, and can't actually send messages, right, to the subsequent neuron, right, that can actually affect obviously cognition, right, processing and reaction time. And we're going to talk about all of those, particularly as we get into not only the SCAT5, but as we talk about cognitive examination as well. Okay. So this entire process, okay, of breakdown of the nerve cell, okay, inability to increase toxicity in the neuron that leads to its destruction, as well as decreased efficiency when sending messages between neurons. That entire process is referred to as diffuse axonal injury. Okay, so this is a correlate and a parallel, right, to our secondary cell death we talked about, that you guys talked about in modalities. Okay, very similar concept in concussion, right? But we see it happening in a different way. All right. Before we keep going, any questions? Stop me if you have questions. Anything confusing?
Not yet.
Not yet. Well, that's surprising because this is actually not easy stuff. So I'm glad that you guys, this makes sense. That's awesome. Okay, very good. Very nice. Okay, moving on. Here's the deal. So obviously, what do we do with this information clinically, right? So there are obviously clinical connections, and we're going to start to kind of see this in class tomorrow when we go over the SCAT5, right? So obviously, the presence of symptoms, right? Um, this has a direct impact on symptoms, obviously balance and cognition. Now, here's the thing, okay? When we talk about blows to the head, okay, we're going to we tend to categorize those blows to the head as either concussive, right, or subconcussive. Now, to be completely and totally clear, there have been a ton of biomechanical studies looking at the force produced, using accelerometers and things like that inside of helmets, that have looked at the force produced with concussion, and it quite honestly varies. We don't really have a magic number for what level of force constitutes a concussive blow versus a subconcussive blow. Okay, for example, okay, a concussive blow usually is going to happen in one single high impact, hit, and or contact, right, with enough force to cause a concussion. All right. Conversely, we have another type of impact known as subconcussive uh, blows. All right. For example, um, it's very so, and you actually do see this from time to time. Uh, we used to see this now and again, and actually a lot of our linemen, um, when I was the football AT at my last school, right? We would see guys that they would be in practice, and they'd be doing maybe it was one on ones, maybe it was uh, 7v7, whatever, right? And maybe they were going half speed, but there would be, just a series of low level blows to the head, helmet to helmet contacts, right? That would occur over the course of a single practice, 1 to 2 days a week. And then eventually you would see someone come up to you and say, "Hey, Wade, can you take a look at me? I don't feel so good. My head is killing me. I don't feel right." Okay. And so and then when you would talk to this person and take a history, what you would find out, right, is that they were generally fine, right? But then in the course of a week, right, just through the continued, helmet to helmet contact, they never took on a single, one single concussive impact. But through the course of, many, many small impacts over time, they began to develop symptoms, right, to the point where those symptoms became bothersome, and then hopefully they would report, right. Another thing that we're going to talk about a lot, toward the latter end of talking about concussion, is one of our biggest issues when it comes to concussion is getting people to report symptoms. People don't want to report symptoms, right? And there are many different reasons for that. Could be due to lack of education, could be due to pressure around them, due to the fact that they don't want to get pulled out. They want to play, right? They want to continue playing, and so they just don't want to say anything, right? So there are many, many reasons for that, and we're going to get into that discussion, uh, as we continue kind of moving forward here. Okay, so I know there's not a ton of words on here, and I'm using kind of some graphics and stuff like that. But the bottom line, guys, when we talk about concussion, okay, we're talking about essentially kind of this melee, right, or this mixture of symptoms, so to speak. Okay, so we have first and foremost reported symptoms, and we're going to talk about that on the SCAT-5. The SCAT-5 is a great tool because it allows us to essentially assess all of these things at one time, right? So we have reported symptoms, right? And so we talked yesterday, we introduced briefly, okay, the graded symptom checklist on the SCAT-5, total of 22 symptoms, for, rated on a scale of 0 to 6, okay, for a max score of 132, right? So reported symptoms, okay. Also, we can see cognitive deficits, excuse me, and there's one way to essentially assess this on the SCAT-5 that we'll learn, right. We'll also talk about a neurocognitive test called impact, and I'm hopefully we can find time. We're also going to try to do a sway lab with Troy as well, to kind of try to get a kind of a big exposure to neurocognitive testing, but also balance testing. um, so also there can be obviously balance and vestibular deficits, right? People can have a hard time with balance after concussion and can also report prolonged dizziness. That's something that we're going to learn how to assess, uh, and also develop some tools to actually treat, in patients as well, right? So the bottom line is that with concussion, it is not uncommon to see a broad array of symptoms within any of these three areas, right? And also, when we talk about cognitive deficits, we also obviously talk about potentially, uh, mood and affect changes, things like anxiety, nervousness, anger, right? So if you know someone to be really laid back and a pretty chill person, and then they have a concussion, right? And all of a sudden they just turn into they get a little mean. They're like, "What the hell, man? Like, what's wrong with you? You're never like this." Well, you never know. I mean, it could be they could have a concussion, right? Particularly if they've had a concussion. Uh, Mood changes, definitely, something to be aware of, because that can happen, right? So we learned, and we've been talking about, right, localizing the lesion in concussion, right? We can't do that yet, right? Not with concussion. We're not, we're just not there. So we've already talked about the fact that sport-related concussion is multifactorial. Okay, so we can't attribute those symptoms, right, to involvement of a specific brain region. We just can't do that at this time, right? So obviously, like we talked about, we're going to have a varied presentation of symptoms. Okay, somatic, meaning what somebody feels and what they report. Okay, cognitive, disturbances and potentially balance and vestibular symptoms. Okay, now the big thing that we'll learn here is that we need to be able to use a multimodal approach when diagnosing concussion, right? So, as we'll learn, here shortly, and as we're going to reinforce, right, over the coming weeks, that no one test, okay, no, and this goes with anything that we do, right? Even in doing like a shoulder exam or a knee exam, no one test that we use is perfect, and no, like we learned about with specificity and sensitivity, right? No one test we use is perfect, and in order to really have the best, outcome and idea, right, for what's kind of going on, and be sure, right, we need to use a myriad, or a kind of a multimodal approach, right? So a multimodal approach to concussion is best, right? And that's the most sensitive and specific way to diagnose concussion, right? So obviously, and I know that this is not, This is not, uh, what am I trying to say? Across the board, right? We don't necessarily see that so much, but the bottom line, guys, is that when you are, potentially designing your own concussion, protocol and or deciding how you're going to do your exam for concussion, you should use more than one tool, right? The SCAT5 is a great tool, but for me, when I was seeing, I saw a ton of concussions, right? Particularly, I also take care of cheer, and so I saw a ton of concussions in football and cheer when I was a collegiate AT, right? And so we always used the SCAT5, Impact, and BESS, right? We never use just one tool, right? Why? So here's the reason. Okay, this is this is a little bit of an older study, but this is actually a good friend of mine who's a concussion researcher at the University of Virginia. Um, and ultimately, what he essentially discovered here, right, is he looked at sensitivity and specificity of these tests, right, of either ruling in a concussion or ruling out a concussion. So, for example, let's just kind of try to break this down for a second. Um, so, the essentially the HIS, by the way, that's essentially a symptom report scale. Okay, so over here in letter A, this we're looking at sensitivity. So the ability to identify somebody with a concussion when they actually have a concussion. Okay, so what he actually noticed here, right, is that you actually when you just relying on a symptom scale, okay, just relying on a symptom scale, okay, you actually are going to only classify 77.5% of your concussions correctly. You will miss, you will actually miss um, about 23K to 24% of your concussions if you only use a symptom scale. All right. And there are different reasons for that we'll talk about. Right. Conversely, if you were to use an impact test, which is a neurocognitive tool, right, on its own to diagnose concussion, you would miss just under half of your concussions utilizing impact as a tool, right? And then the sensory organization test, which is essentially is a computerized balance test, if you were to use that as a standalone tool, right, we actually uh, would miss, right, more than a quarter of our concussions when utilizing that as a standalone tool. But okay, and you could make the argument, well, it's not much better if you use all three, right? And you might be right. But okay, a battery of tests, right? So using all three of these together, okay, results obviously in an 80% sensitivity. So the ability to correctly identify 80% of patients as concussed when truly concussed. Okay, and so we can see also on the specificity. Um, oh, so you know what, guys? I totally just misread that. So sorry. So ultimately, right? So looking at sensitivity, um, at the same time, utilizing right essentially clinical interpretation guidelines within these tools, and that's something that we'll talk about. So, like with Impact, for example, it actually has a set of essentially a user guide, right, for essentially allowing you to interpret results. So, for example, okay, if we look at the graph on the right, okay, utilizing a battery of tests, okay, in this case, you'll actually correctly identify and diagnose 100% of your concussions, right? Um, Generally, okay, and it might be a little lower than that when utilizing these tools appropriately, right, as a test battery. So I think we get the idea, right, that when we are evaluating or diagnosing concussion, that we need to use more than one test. Okay. There's also another test that's not pictured here because it came out after this article was published, called the VOMS, and you guys use the VOMS downstairs, right? And so we're actually going to learn. Okay, balance testing. We'll learn BESS. We'll learn the SCAT5. We'll learn a little bit about impact as well, and then we'll also use VOMs as well uh, in our protocol that we're going to learn, right? So, how many of you just out of curiosity, have been involved in a concussion evaluation downstairs? What do you guys typically do?
Um, I helped with one in the fall, and like I couldn't really do anything besides just like watch them and make sure they were taking the sway test like the right way and not
Sure.
cheating.
Okay. Okay. So what, I mean, we're actually almost finished with the lecture for today. Um, but I mean, does this prompt any questions for you guys? I know that, like I said, this is not, it's not necessarily easy information, but you guys appear, doesn't appear to be a problem for you, which is fantastic. Um, what questions does this bring up or prompt? None. And if that's, I mean, if that's the case, I guess that's also good. Nobody's confused. Okay. Well, I guess that's a good thing. I'll take that. So, okay, fantastic. All right, guys. The tool that we all know and love and that we're going to be oh so familiar with by the time we're done with this, right? The SCAT5. Okay. So obviously, like we talked about, the SCAT5 is really is the gold standard that's been essentially promoted by the Concussion and Sport Group, and this is the most widely used tool, right? To obviously to assess for a concussion, right, on the sideline and obviously in a clinic environment as well, right? And so we talked about the fact yesterday. No, it was Monday. We talked about Monday that there are essentially a group of conditions that we call modifiers for concussion, right? So previous head injury with hospitalization, maybe they had a bleed, right? Um, okay, maybe they have migraines. Okay, maybe they have dyslexia, right, or a learning disability. Um, how do you think, by the way, how do you think dyslexia might affect someone's ability uh, to be evaluated for a concussion?
I mean, like remembering the words might
Yeah,
be difficult.
remembering the words and or even maybe reading things, maybe seeing the letters actually uh, in a different order than what they actually appear, which is something that people with dyslexia struggle with, right? They will often see letters in a different arrangement, as opposed to the way that the word is actually written. Obviously, people with ADD or ADHD, right? This is you know due to obviously difficulties and struggles with baseline focus and attention, right? This can actually influence the results of a cognitive test, right? And so these are things that we need to be really, really aware of when evaluating people cognitively as well. Okay. So, all right, guys, that is it for today. Um, any questions about this at all? This is being recorded. I will send you guys the video link and the PowerPoint. I'll put this on Moodle. Like I said, I've got to finish getting freaking Moodle cleaned up, and I'll have that a little bit better organized for you guys. Um, no other questions?
I do got one.
Izzy.
So, with the difference between the subconcussive and just the regular one,
Yeah,
like, would you still do like the exact same testing the exact same way?
absolutely yes. Right.
Okay.
So the main difference is between concussive blows and subconcussive blows is just simply how they occur. Right. The symptoms are still the same. Right. That person is still experiencing uh, the same type of symptoms. Right. And difficulties, but the point that was being made there was that they can still get right. So let me tell you a story. Here's kind of a story, and then maybe this will help illustrate this point a little better. So Texas is kind of a different state when it comes to regulation of athletic trainers. We have, and this is not necessarily a bad thing, but you can take a state licensure exam in Texas and become an athletic trainer, and that's all you have to do. So theoretically, you could not take your BOC and still be an AT in the state of Texas. And there are people have fought that, and there are some issues with that, right? And I even took my state board exam before I took my national board exam, because that's just the way it was. But I was once having a conversation with an athletic trainer. We were covering an event together, and brought a kid in that had a concussion, right? And this was like, it was like a charity football game, okay? And we were practicing, and the athletic trainer looked at me and he said, he's a good guy, and I don't want to like speak derisively of this person, but he said, "We're not hitting hard enough to get concussions." It's like, doesn't really matter if you think we're hitting hard enough or not. The kid has symptoms, right? The biomechanics are there, right? And he has symptoms. It doesn't really matter what you think what you think the impact should be, right? So this kid sustained a concussion via subconcussive blows, right? So the point being is that these symptoms can happen in two different ways. We can have the big concussive blow, right? Or we can have a series of small blows over time that cause the same symptoms, right?
So basically, they still accelerate like the whole protocol or whatever, like the day by day thing still is the same.
Yeah, nothing changes based on that mechanism. The only point that was being made there is that there are two ways, generally speaking, that someone can become concussed: through through a high energy concussive blow, or through a series of subconcussive blows. Another way too that's been reflected in some of the research and literature is actually looking at soccer headers. Actually, soccer players reporting concussion symptoms after heading the ball continuously, right? So does that make sense?
Yeah.
Okay. Is that helpful as far as that explanation?
Yes.
Cool. All right. Nothing else that you guys have? Okay. All right. Well, you guys have a great day. Oh, all right. You guys have a great day in every way. You guys are great. I appreciate all of you. And tomorrow we're gonna jump on that scat 5. Okay. It's gonna be fun. Maybe.
Sounds good.
Okay. You guys have a good day. All right.
You too. Bye, Wade.
See you tomorrow, Wade.
See you tomorrow.
Bye.
Bye.
See you,
Bye.
Wade.